All right, part three of my day. My wife keeps calling me. Anyway, um, again, 12/21/2020. I only have about 15 minutes before I leave here to head to the gym. So, all right. So, okay, we were talking about this patient, two-level ACDF. She was actually doing extremely well, really well. Minimal neck pain, upper extremity symptoms resolved postoperatively. So, next patient I saw, 34-year-old female with a traumatic pelvis fracture, and she continues to have pain. Actually, it was a sacral fracture, right-sided sacral fracture. She continues to have pain, but is gradually improving a little bit at a time. And really, unfortunately, there's nothing that we can do for a sacrum fracture. Um, and also, that's fortunate and unfortunate. Because who wants to have surgery, right? But it'll heal on its own and usually be pain free once it does heal within 6 to 8 weeks. So she's doing better and doing a little bit more. There's nothing that we can really do but continue to get some x-rays and kind of follow it. So, and I did see a step off on the x-ray where the fracture was. And it can be hard to see with the sacral x-ray. Okay. Next patient is pretty young as well. She's an interesting 28-year-old female with chronic coccydynia or tailbone pain. Ordered an MRI of her coccyx and sacrum, and they were pretty normal. But she does have a hyperangulated sacrococcygeal segment, meaning that where the sacrum and coccyx come together, it's a little bit overly angulated. Yes. So she has this chronic pain, and the only thing that we can do for that is remove her tailbone. And that's what we're going to do. Now, that being said, I've never participated in a surgery such as this, so this will be my first one. But we are scheduling her for coccyx removal. Okay, that was my office manager. Kim, where are you? Asking me to pick out some different pickups because the ones I used today didn't work well. So y'all could probably meet her. But okay, who's next? Let's see. All right. Oh, geez. 44-year-old female who we did multi-level anterior, posterior, interbody, and posterior lateral fusion for significant degenerative disc disease and lumbar stenosis. Her surgery was greater than a year ago, and then we went back and removed the posterior hardware in January of 2020, and she continues to have some significant pain. Her pain now is primarily right lumbosacral over the SI joint. I referred her to pain management. They did a right SI joint injection once, and it relieved all of her pain, but only for a few weeks. The second right SI joint injection did not help her pain whatsoever. So that puts me in a dilemma. We can't really, it'd be hard to recommend any further surgery like an SI joint fusion with only one positive response out of two injections, especially knowing her history of not really doing exceptionally well with surgery. She had a prolonged hospitalization postoperatively. She had suboptimal results. The SI joint fusion surgery is minimally invasive and works pretty well. So, however, again, I don't want us to operate on somebody who's not going to get better. And so I'd like for her to have another right SI joint injection with her pain management specialist, and hopefully get a good result from that, so we can recommend the SI joint fusion. So. She's kind of a challenge. She's definitely a challenge to manage all of her symptoms and everything she's got going on. What else about her? Oh, the SI joint. The SI joint is innervated by three nerves, and sometimes it's very hard for the SI joint injections to hit all three nerves. If you go a little too far, you can inject the steroid and the lidocaine outside of the joint. You don't get the effect. I know that they use intraoperative radiographs or C-arm for these injections. But Dr. Butler and we went to a course on the SI joint fusions. We talked about the injections and how a lot of the injections are not accurate even with C-arm. So, um, so that's a kind of a lesson on that on the SI joint. So, all right, all right. This patient's 59-year-old female with some chronic neck pain. She has a history of a previous cervical fusion. This is only her second time coming in. After her initial evaluation, she was referred to physical therapy. She has since been doing physical therapy, which has helped minimally. So therefore, at this point, we are going to order an MRI of her cervical spine. So that was a relatively straightforward follow-up appointment after initial evaluation. Okay, so next patient I saw is a 24-year-old male in the Army National Guard, originally injured about 2.5 years ago out of state, injured his back, and then re-injured himself recently with activation due to COVID-19 on state orders. So he's essentially a state workers' comp patient. Okay. When I last saw him, we reviewed his MRI, which showed that he had some lumbar facet arthropathy or arthritis. At that point, he was already in physical therapy and had made some progress with mobility, but no improvement as far as pain goes. So I referred him to pain management for medial branch blocks of the lumbar spine. Now, the medial branch innervates the lumbar facets. And so essentially, the medial branch blocks numb the lumbar facet. So if you have facet joint mediated pain, it should improve with the numbing shots. If you get 2 of those shots done and you get a significant improvement, however temporary, then you can burn those little nerves and basically trick the brain into thinking you don't have lumbar facet arthritis or facet joint pain. So anyway, I sent him to pain management to have the injections done. He had 1 set of injections done on the left side, and they did reduce his pain. So they did the injections, and then they called him 48 hours later to check on him and see how he was doing. He said my pain was improved. I was able to find this in the chart. So the pain management specialist specifically said, well, let's try the radiofrequency ablation, which is the burning of the nerves. Well, he submitted that to workers' comp, and workers' comp denied the procedure, stating that there was no documentation that he improved with the medial branch blocks. Well, apparently either they didn't read or didn't have access to the telephone notes between the pain management physician and the patient. They also denied on the basis of the fact that the patient didn't have physical therapy. Well, that's false because the patient did attend physical therapy, and in fact, physical therapy recommended that he continue going and requested further treatment, which was denied by workers' comp. Go figure. So anyway, I tried to dictate all that, be as accurate as I could, so that we could try to get him approved for the for the rhizotomy procedure. So, all right, who is next? All right, next patient. As a guy I know well, we've operated on him a couple of times. We've done a multi-level lumbar discectomy and fusion, anterior and posterior. He's got a horrible spine. Last time he was here back in August, he was having a lot of issues with his neck, significant severe cervical stenosis with myelopathy, a lot of falls, multi-level degenerative disc disease in his neck, and spondylolisthesis. We recommended or felt like he needed an anterior and posterior cervical fusion and decompression, and recommended that he go to a higher facility to get this done. Instead, he went to a local neurosurgeon and had the procedure done, but actually did not have the procedure we recommended done. He had the anterior cervical fusion done at 3 levels, okay? And the plan was with this particular neurosurgeon to stagger that and have the posterior surgery done later. Well, he shows up today, and actually he called me. He has my cell phone number. He called me over the weekend and asked me if he can come in today, and I put him on the schedule. Very few patients have my cell phone number, but this is one of them. So he came in today. He's extremely kyphotic, forward head, still struggling with all his symptoms. The anterior cervical fusion by x-ray looked okay, but really the posterior spinal stenosis was the major issue that needed to be corrected. And he hadn't had that done yet. So we discussed this for a while. I talked to him about his pain management and his options there and what I thought he should do. And I gave him some referrals to some other neurosurgeons that like to do a lot of posterior cervical stuff. Next patient I saw was 84-year-old female with lumbar facet arthropathy, chronic low back pain, doesn't want surgery, doesn't want pain medication, and so I gave her a referral to a physical medicine and rehab specialist who she has seen in the past for some mildly interventional procedures like trigger point injections that have worked well for her, and that's all I had to do with her. All right. Next patient I saw was a 79-year-old male with previous multiple lumbar surgeries with persistent lower extremity pain. He's also status post some vascular procedures for the leg for the vascular disease. So, where am I at here? Oh, I'm sorry, I was getting distracted. So we ordered a bilateral lower extremity EMG and nerve conduction study. To review that today, he's basically got some chronic nerve damage without any acute irritation to the nerves and some neuropathy. So unfortunately, his leg pain is going to be permanent. He's already taking gabapentin, 900 milligrams 3 times a day, which is the maximum dose, and occasional opioids for pain from his primary care. The next patient I saw, well, it's getting kind of late, and I'm heading to the gym. So I saw 1, 2, 3, 4 more. I'll go over those 4. Okay. So next patient I saw was status post C3 through C6 anterior fusion with corpectomy of C4 and C5. So we removed the vertebral bodies of C4 and C5, and we did a fusion. He had significant stenosis and right upper extremity symptoms prior to the surgery. He came in today with some persistent right upper extremity symptoms and muscle spasm and pain on the right side. I gave him a trigger point injection and ordered physical therapy, which we've already ordered, but really put an ASAP on it for him to work with therapy and work on the muscle spasm and his range of motion and function. He's going to be a pain management issue, knowing his history. So, next patient I saw is workers' comp. Chronic cervical degenerative disc disease and facet arthropathy, as well as lumbar. He gets occasional exacerbations of his symptoms, and I usually refer him to an established pain management physician that he's been seeing for years to repeat either the cervical or lumbar injections, each about once every 18 months. So the last time he was here about a month ago, I recommended that and put the request in to repeat the cervical injections because he was having an exacerbation of cervical pain. Well, unfortunately, he was denied by workers' comp because they said that he needed some physical therapy. And so a physical therapy order was put in, and they denied that too. So workers' comp sometimes doesn't know why they deny things. Not all of them, but, it depends. Depends on who you get. So anyway, I gave him 2 trigger point injections on the right side of his neck, and again, recommended repeat of the cervical injections done by his established pain management physician in the past on several occasions. Next patient I saw was for left shoulder pain. He just wanted he has subacromial bursitis and some rotator cuff impingement, and he wanted a repeat subacromial corticosteroid injection so he could finish out hunting season. And then after that, he was going to get an MRI and consider having surgery. So that was pretty easy and simple. Next patient I saw was 35-year-old male to follow up and review an MRI of his left knee and his cervical spine. He has some chronic neck pain and muscle spasms in his neck. The MRI was not extremely impressive. He did have a disc bulge at one level and some facet arthropathy, and I wound up referring him to pain management to evaluate and treat him. The left knee was more painful than the neck, and a lot of his pain was focused at behind the patella at the most inferior part. The MRI did show that he had some fissuring of the cartilage behind the patella, and that's very difficult to treat. So we started out with just an intra-articular corticosteroid injection a day. I'll see him in a couple of weeks, and if that's really bothering him still, then we could do a knee arthroscopy to try to clean up some of that cartilage damage. So cartilage does not heal very well because it has a very poor blood supply. So is that it? That's it. All right. I'm done. I will post all three of these videos. Have a good evening. Also, I'm going to post about some surgical stuff that we did last week and my clinic from last Friday.